Acute visual loss. It's one of the most terrifying things a patient can experience. And for you, the clinician, the clock is absolutely ticking. So today, we're going to build a really clear, structured framework that you can use right at the bedside to navigate this incredibly high-stakes emergency.
All right, here's our game plan. First, we'll get into the patient's shoes to understand what they're going through. Then, we'll nail down how to define the emergency. After that, we'll cover the first few questions that can instantly narrow your focus. Then we'll split off and tackle two classic presentations, the painful red eye versus that silent painless vision loss. And we'll wrap it all up with a powerful diagnostic tool you can use in literally any exam room.
This quote really says it all, doesn't it? For the patient, it is just sheer terror. And for us, that terror translates into a huge responsibility. Every single minute counts, and honestly, our initial assessment can be the one thing that saves their vision.
Okay, so our whole investigation kicks off with one fundamental question. Is this vision loss sticking around, or did it come and go? Believe me, your entire diagnostic path is going to hinge on the answer to this one.
That 24-hour mark, that is our critical dividing line. If the vision loss is transient, so lasting less than a day, you have to treat it as a TIA of the eye, what we call amaurosis fugax. That means you're kicking off a stroke workup. But if it's persistent, well, we're dealing with a totally different set of emergencies, and that's where we're going to focus our attention right now. So, how do you cut through a massive list of possibilities? It turns out you can do it with just 3 simple questions. Think of this as your rapid triage framework to immediately sniff out the highest risk scenarios.
This is your first pass red flag screen. Did they just have eye surgery? You've got to suspect a deep infection like endophthalmitis. Are they a contact lens wearer who comes in with a red eye? Then corneal ulcer. And any history of trauma, you're immediately thinking about things like a bleed in the eye or maybe a retinal detachment.
All right, let's zoom in on a classic presentation, the painful red eye. It's a super common complaint, but the potential causes have wildly different levels of urgency. This table is fantastic for sorting through the big 3. Keratitis feels like something stuck in the eye. Uveitis is all about that painful sensitivity to light. Both of those need to see ophthalmology within 24 hours. But acute glaucoma, man, that is in a league of its own. We're talking a deep, nauseating ache and a fixed mid-dilated pupil. That is a sirens blaring, get them to the ED right now emergency. So why is glaucoma such a massive emergency? Just look at the pressure. Normal eye pressure is around 10 to 21. In an acute attack, it can rocket up into this range. That kind of pressure is literally high enough to crush the optic nerve and cause permanent blindness in a matter of hours. The takeaway here is simple, and it is non-negotiable. If you even suspect acute angle closure glaucoma, the patient goes to the emergency department. Immediately. There is no other option. Period.
Okay, let's pivot to a presentation that can be even trickier. Painless vision loss. The lack of pain is so deceptive, right? It often makes patients delay coming in, but the underlying problems are just as sight-threatening.
So when vision loss is painless, our differential diagnosis shifts to the back of the eye. We're thinking about problems with the vitreous, the retina, or the optic nerve itself. Let's break down some of the biggest players on this list.
You need to listen for these buzzwords: flashes, floaters, and that classic description of a curtain or a shadow falling across their vision. That is highly suggestive of a retinal detachment. This is another one that needs an urgent ophthalmology evaluation to prevent permanent vision loss.
This is one of those classic medical phrases you just never forget. Blood and thunder is the textbook description for a central retinal vein occlusion, or CRVO. And it describes exactly what you see on a fundoscopic exam. A retina just ravaged by widespread hemorrhages and swollen veins, all because of a clot in that central retinal vein.
So what about a central retinal artery occlusion, or CRAO? The absolute best way to think about it is as a stroke of the eye. If a CRVO is usually a clot forming in the vein, a CRAO is typically an embolus blocking the artery. This analogy is perfect because it immediately tells you how serious this is and how fast you have to act.
And you guessed it, just like a brain stroke, this means an immediate trip to the emergency department. The goal is to get a full stroke workup and maybe even consider some emergent interventions to try and get that blood flowing to the retina again.
Okay, for any older patient who comes in with sudden, painless vision loss, especially from something ischemic like a CRAO or an ischemic optic neuropathy, you have got to have giant cell arteritis on your radar. So you start looking for these other symptoms. A prompt diagnosis here is absolutely vital because treating it can save the sight in their other eye.
Let's be crystal clear about this. You do not wait for a biopsy. If your clinical suspicion for GCA is high, you start high-dose systemic steroids immediately. The whole point is to prevent the patient from going blind in their other eye, and that takes precedence over everything else, including a definitive tissue diagnosis.
Finally, let's add one of the most elegant and powerful tools to your bedside toolkit. This one simple move can tell you with pretty good certainty if the problem is located in the optic nerve. And that is the afferent pupillary defect, or APD. It's a pure sign of a problem with the afferent pathway. That's the signal getting from the eye to the brain. Finding an APD is a massive clue that immediately points you toward optic nerve issues like optic neuritis or ischemic optic neuropathy. The technique itself couldn't be simpler. You dim the lights, and you swing a bright flashlight from the good eye to the affected eye. Instead of constricting like it should, a pupil with an APRD will actually look like it's dilating as the light hits it. It's subtle, but it's an incredibly specific and useful sign.
So, this is where we end. You've got the framework now. You know the red flags to look for. The final question is always the same. Who are you calling, and what are you going to say? Because taking all this knowledge and translating it into a clear, concise, and urgent call, well, that's the final critical step to saving your patient's sight.